Welcome to the Heart Center in Trier. My name is Nikos Werner, and I'm sitting here with Professor Holger from the University Heart Center in Gießen, and we want to welcome you very much to this web symposium. The topic of today is challenging calcified lesions, and we are happy to have you here. Probably most of you don't know the city of Trier, so we maybe need to explain something. It's actually the oldest city in Germany, and it used to be the largest city outside of Rome when it was back in the Roman times. So we are very happy to have you here, and we had some interesting cases yesterday, Holger. We want to discuss today all about the challenging calcified lesions. And again, Holger, very, very warm welcome to Trier. I'm really happy to have you here. Holger is a really renowned expert in coronary intervention. He has a lot of experience with complex lesions, with calcified lesions. He has published a lot of papers and done a lot of studies, so it's really a great pleasure to have you here.
Thank you for having me.
You already heard that. We had cases yesterday. We worked the whole day to get some nice cases and some nice coronary interventions for you. At this point, I would really want to thank the hospital administration, and the nurses in the cath lab, and all the other physicians who helped us with the case, with the setup, and also from the company, from InCathLab and Shockwave. So I think we can proceed to the first slide to present you the agenda for today. It's all about the challenging calcified coronary lesions, and we want to dive into the intravascular lithotripsy, IVL, that's the shortcut, intravascular lithotripsy, and we want to discuss with you today the clinical utility of the intravascular lithotripsy. We want to talk about the best practice when using IVL, because as you probably all know, this is a new technology. It's a novel technology where we need all to get more experience, to get more insights, and I think this is something what we want to discuss today, some of the best practice objectives. Also very interesting, and you have maybe seen some recent publication on that, are the algorithms when and how we can use IVL in our clinical practice. These are very interesting and complex questions because we have a standard procedure for calcified lesions. We can use different types of balloons. We can use scoring balloons. We can use ultra-high pressure balloons. We have the option of rotational atherectomy, at least in Europe only. That's the only what we have at the moment. So we have some standard procedures, and it's now the big question how we can include the IVL, the lithotripsy, into our daily practice. I think something which is really interesting, and I'm really looking forward to discuss that with you, Holger. And the final point is we want to discuss with you intravascular imaging and how it can help to optimize complex procedures. I think we have a lot of different modalities we can use for imaging. It starts, of course, with the angio, but it also includes, of course, IVUS and OCT. And especially in these challenging, complex calcified lesions, there's still a debate going on that when and how to use intravascular imaging. I think it's clear from the studies that we have a benefit when we use it. But if you look into daily life practice, in a lot of cath labs, it's only occasionally used, and more or less people rely on the angio, sometimes because it's faster and quicker, sometimes the interpretation of the results are difficult. So there are a lot of obstacles arguing sometimes against this intravascular imaging. And I think this is something we can discuss also during our web symposium. So the next slide, please. Maybe, Holger, we start that you explain a little bit about the technology. I just mentioned lithotripsy. I think not everybody is very familiar with that technology because it's really new. And maybe you can give us a little bit of an insight on how this technology works.
Thank you, Nikos. First of all, thank you for having me here, also here in the oldest city of Germany, here in Trier. It's my pleasure to be here. Well, Nikos, as you said in your introduction, this is a very new system, the Shockwave Coronary IVL system, which means Intravascular Lithotripsy. It comes with a compact and rechargeable generator, which you can see there, and a connected cable. Through this cable travels the energy to the catheter, and the IVL system is just a simple balloon containing 3 emitters, which you can see on the tip of the balloon catheter. We have this also, as usual, this distal and proximal marker bands, and so through these emitters, the energy is applied. Well, the system at all is very intuitive. Everybody who is using a normal balloon probably can also use this new system. If you see at the next slide, you may see the mode of action of the intravascular lithotripsy. So the generator generates an energy of 3 kilovolts, and this energy travels through the catheter to the emitters, and these emitters creates an acoustic shock wave, and this affects the different layers of the vessel, and while other devices cannot affect and differentiate between soft and calcific tissue, the sonic pressure wave and the IVL system can differentiate, only affecting the calcific tissue layers. So how does the acoustic waves are generated? A small electrical discharge vaporizing the fluid inside of the balloon, thereby creating a rapidly expanding bubble, and this bubble collapses within microseconds, and both the expanding bubble as well as the collapses creates this pressure waves affecting the vessel wall with almost 50 atmospheres to create some microfractures in the calcium layers. So I think these are the most important thing. Worthwhile to mention that the balloon is only inflated to subnominal pressure of 4 atmospheres, just to have this fully position to the vessel wall, and thereby transmit the energy from the emitters and the balloon to the vessel wall to crack these calcified structures. Well, yeah. So I think the mode of action is explained, and Nikos, for you the question, we have some data out there. We have registry and trials. If you look at the Disrupt 1, CAT 1 and 2, one contains of 60 patients, the other 120. The question is, can you explain a little bit of the results of the trials and what are the information coming from these registries?
Yes, I think this is very important because we have only limited data, as you mentioned. We have the CAT1, CAT2 trial. We have a lot of different registry data and case reports. And when you put that all together, I think there are some really important messages. I think the first important message, and that's what we see in CAT1 and in CAT2, is this is a very safe procedure. You mentioned you only dilate with 4 atmospheres, and then you have these shock waves going through, only hitting the hitting the calcium. There's no signs, and this is, I think, very important. There's no signs of embolization, for example, like we see it sometimes with Rot Ablation, that you have some debris going off. We don't see that, and this is one of the, I think, most important things what we learned from the initial studies from Disrupt-1 and CAT2. That is a very safe procedure because we are working with only low pressure. We don't have any signs of distal embolization, so no risk of no reflow, something like that. And as you can see here from the safety data from CAT1, there were virtually no severe dissection. There were no closure of the vessels, no slow or no flow phenomenon. And also when you look at the 30-day MACE data, I think very favorable results. However, you have to keep in mind this was only a limited number of patients, 60 patients in this study, but in all cases, and this is shown in the lower right part, the performance and the clinical success was very high. So in very calcified lesions, there was a safe and effective procedure possible. And when you go to the next slide, we see the sub-study of the OCT sub-study of the CAT1 trial, where we see the degree of calcification in the stenotic lesions, so very heavily calcified lesions. And there were, as you can see in the middle, some fractures into the calcium. That's what we typically see after using the balloon. And remember, again, only 4 atmospheres, but the sonic shock waves, they induce these cracks into the calcium. It's like a safety windshield in the car. You get the cracks, but nothing prolapses or embolizes into the periphery. And I think these are very important points, what we have learned from the studies.
Well, I think it's obvious that it's not only in theory that you have these microfractures. You can directly see that microfractures on the OCT, which I think is very impressive. You can see this in the upper panel in the mid part. So there are 3 fractures just having created this very compliant vessel again, so that an huge expansion can follow to the predilation of the stent. So this is, I think we know that under expansion is one of the most important point we have to address if we implant a stent, because we know that it's creating a high TLR if there's an under expansion. And this is a nice example you showed up with the OCT here in the sub-study.
The interesting thing is when you look directly, you see that that you get this crack circular. You have a circular, the balloon is giving cracks into the calcium in a circular fashion. And this is, I think, very interesting, because when you use a normal balloon, you never know where it ruptures the plaque, and you don't know if it's really at different points. It's normally at one point where it ruptures the plaque, and here you can see that there is circular disruption of the calcium, and which allows really to soften the plaque, the calcium in some kind.
Well, there's a good point you made, because if you have this intravascular preparation with the Rot Ablation, for example, you have not this circular effect of the Rot Ablation, but only very regional. So this could be one of the most interesting topics coming with the IVL, that you have indeed these circular results after treatment of the vessel. Well, so Nikos, I think we have to look also at the CAT2 trial, where we have a higher number of patients, and I think we have also the information about the point, is there maybe more procedural myocardial infarction? You have told us that with the Rot Ablation procedure, for example, we have this no flow, slow flow phenomenon. Yes. We have this procedural increase of troponin, and which comes along with the myocardial infarction, as we know. And so the 120 patient from the CAT2 trial confirms the safety. Maybe you can explain some of the results in detail.
Yes. So maybe we have a closer look at the slide of the CAT2 trial. We start in the upper left, the performance outcomes. I think very convincing data on clinical success, 94%. Angiographic success, 100%. So I think very convincing data in terms of performance. Stent delivery was no problem. And one of the important points is that the residual diameter stenosis was in the range of 7 to 8%. I think excellent results. Below that, you see the acute gain and the residual diameter stenosis. So I think very, very convincing first results of these 120 patients. And again, as you already mentioned, very favorable safety, low in hospital MACE rate, and again, no perforation or any signs of other difficulties during the procedure, during lesion preparation. I think this is something very important. And again, together with these safety outcomes, high acute gain and low residual stenosis, two parameters we are looking very close at in these complex lesions, because this is the only parameter where we can really evaluate and say if we were successful with our stent implantation. And these are excellent parameters where we can judge the risk of in-stent restenosis in the near future, even in the drug-eluting stent area. So if we see today in-stent restenosis in drug-eluting stent, it's often that we have under-expansion of the stent, and these are all the cases where we have heavy calcification. We underestimated the degree of calcification, put in a stent, and had a significant residual stenosis and not enough acute gain. And these are the patients, I think, who develop in-stent restenosis in the future.
Thank you, Nikos. I think just to summarize, what we have learned from CAT1 and CAT2 is that the procedure is very safe. Yeah. Just to point out that there is no perforation at all. You can assume that maybe the vessel wall can be affected by these shock waves coming with 50 atmospheres. Yes. But there was no perforation at all. There was only mild dissection. And if you look at the slow flow, no flow phenomenon, we have not seen any of these phenomena coming from these trials. And the second thing is we have learned from CAT2 trial that we have a high lumen gain. Yes. After treatment of the IVL, even if we have only treated the vessel with 6 atmospheres. And as you mentioned before, and this is, I think, a very important thing to summarize. So, Nikos, I think we are ready to go into the live cases or the recorded cases, which we have done yesterday. And may I ask you to introduce us to the first case?
Yes. So maybe we start with the first case. There are coming in some questions. I think it's the easiest that we answer these questions during the symposium. And some of these questions will, I think, already be answered with the first case. So I think it's a good idea to start with the first case to present. We had a patient with a calcified mid Rca lesion, 79-year-old male. not so many risk factors, no diabetes, no chronic kidney disease, not something typical what you normally see in these patients with heavily calcification. But he had a 3-vessel disease. He had a STEMI back in 2015, which was treated with a stent. Other past medical history included a prostate cancer back in 2009. So this patient presented to our hospital with dyspnea, New York Heart Association stage 3, and typical angina. He is on a typical coronary medication with a beta blocker, AT1 receptor blocker, statin. All, I think, on a very, very stable basis, but he clearly developed over the time typical angina on exercise. So next, please. So what we did with the patient, we did, of course, coronary angiography because of this very typical symptoms of the patient. We did a pressure wire, the Comet pressure wire in the RCA, which was positive. And due to heavy calcification, which was also already seen on the angio, we planned the procedure with the IVL lesion preparation, and also, and this is something what is also questioned by the audience, whether you have to always use some kind of imaging when using IVL. We will discuss that a little bit later. In this case, we used OCT to get a deeper impression of the calcification. You will see in a couple of minutes. So the clinical indication in this patient was exercise-induced typical angina, which was on a standard therapy, came up on a standard therapy, and a DFR positive coronary lesion. So these points brought us to the point that we wanted to use the IVL shockwave system in this patient with a heavily calcified mid RCA. So the next, please. We start with the case and the video.
So, Nikos, thank you for this nice case introduction. And as you already mentioned, we have this intermediate lesion at the mid part of the right coronary artery. You can see the angiogram on the right-hand side. And so coming from the angio alone, the question is this information enough from the angiography to decide directly go with a normal standard procedure, or if we have to use other devices like non-compliant balloon, or do we have, for example, debulking devices like scoring devices, angiosculp, cutting balloon, or at least Rot Ablation, or IVL. So we are here to discuss that.
Mm-hmm. Yeah, I think when you look at the film and from the beginning on, you can see, you can appreciate already the heavy calcification within the whole RCA. I think from an angiographic standpoint, you can already see that there's a lot of calcification in the wall. So the problem is, as usual, that it's very difficult to judge whether this calcification will bring you into trouble or not. This is, I think, the important point. And normally you don't know that from angio. You see the calcification, but if this calcification brings you into trouble because the balloons doesn't open up or anything like that, that's what you don't know. Same holds true for any lesion preparation device. I mean, we all know these lesions where you think, well, I can go in with a non-compliant balloon, open up, well, let's see how it works. And then the first step is you don't get the balloon into the lesion. Or you choose a lesion preparation dedicated balloon, for example, and again, you see that you can't advance the device into the lesion, for example. And this is all about the calcification, the type of calcification, whether you have calcium prolapsing into the lumen or if it's quite smooth calcium. And this is something what you can't see in angio, that's for sure. Therefore, I think it's always important to have some kind of imaging at the start of the procedure so that you do IVUS or OCT. That was a question, why using OCT and not IVUS? I think this is something which is really to the discretion of the operator at the first hand. You are a guy using a lot of OCT. I'm personally using a lot of IVUS, but I think it really depends. You can see calcium in every of these modalities. You can nicely see it in OCT, but you can also nicely see it in IVUS, for example.
Well, there are some other patient-limited situations where we have the renal failure, for example, or the Ostia lesions where we cannot use OCT in the usual fashion, so as we use it in other situations. But and the other point is that I want to make is, of course, we have the possibility with the OCT that we can look into the vessel wall and we can look behind the first layer of calcium, so we can assume what is the thickness of calcium, because this could be very interesting to decide, is a debulking device enough, or do we need rotational atherectomy or IVL? So if you look just at the slide we prepared, so the benefits of intravascular imaging is for me crystal clear. However, some of the physicians out there are a little bit reluctant using the OCT, and of course you do not need the intravascular imaging in every case. However, as long as you might appreciate some difficulties during the procedure, the intravascular imaging can guide and help you to proceed in a very easy fashion with the procedure. So if you look at the three states where imaging is helpful, so you have the pre-dilatation situation where you can estimate what is the calcium arc. It is circular. Do we have a concentric or eccentric calcification? What is the depth and the length of calcium? We spoke about that, and I think this is also very important to have this information regarding the next steps. Then what happens after treating a patient, especially if you used the IVL, but this is also true for other devices like Rot Ablation. So you want to know, was it effective, what you have done so far? So we call that calcium modification analysis. And of course, finally, we have this evaluation after stenting. Do we have an under-expansion or do we have malopposition? Of course, the malopposition purpose is very interesting to talk about. However, I think more important is the issue of under-expansion. And with the OCT and the software of the OCT, the MSO, you can nicely demonstrate, if you look at the two parts of the stent, the distal and the proximal part, which part is under expanded in relation to the reference vessel lumen, proximal or distal. And I think we have a nice information setup coming from the intravascular imaging to have the best result in our patients, and that's what we are looking for. So I just want to emphasize a little bit the point that we have a lot of advantages coming with the intravascular imaging, not only from OCT, but especially in calcified lesion, I guess. We can use it in a very nice manner. So.
Okay, so maybe we can come back to the case again. We were a little bit too fast, I think, in the beginning. So maybe something for the setup. We used a RDC3 guiding catheter, 6 French. a standard wire. In this case, it was a Samurai workhorse wire, nothing special. Just a workhorse wire and a normal catheter, not with a lot of backup, just a regular catheter. It's 6 French compatible. In this case, we had to use the femoral access because the radial access was not possible. It was quite easy to bring the wire down, and then we did the OCT analysis. I think you can see that here. The OCT analysis showed really heavy calcification. That's what we were expecting. Holger, maybe you can tell us a little bit more about the features, what we saw, because it was really interesting and some kind surprising what we saw in OCT. So a typical case where you think, well, it's a standard calcification, but we saw some very interesting features and things.
Well, if you can run the video, so you can follow me a little bit, and you can see that we have this huge calcification directly. Maybe we can go a little bit back, because there we can see the calcified nodules, which is directly the culprit of these lesion. And of course, we have seen this special morphology of the lesion, where we are, I think, a little bit helpless if we only balloon these kind of lesions. So just summarize a little bit the intravascular imaging. I think we have this heavily calcified lesion in length about 25 millimeters. We have a very deep, or the depth of the calcium is more than 0.5 millimeters, which is also very interesting. We could measure that very nicely with the OCT. And if you look at the length, as I told before, we were above the 5 millimeters, which is very important if you think about the 5 rule coming with calcified lesion. And
maybe you can explain that a little bit more.
Well, this is we have these 3 aspects of a calcified lesion, where we have to think of more or a proper lesion preparation, which is the calcium arc of more than 180 degrees, the depth of the calcium more than 0.5 millimeters, and the length of more than 5 millimeters. And if all criteria are fulfilled, so this is of course a very heavily calcified lesion, where not only a balloon is working, but also the bulking device such as IVL or Rot Ablation should be applied to this kind of lesions. And all these 3 criteria were present in the OCT, which is a very, very important information just to proceed in the right manner.
Okay, just a question at that point. You said that OCT is helpful because you want to see the thickness of the calcium. Is that not exactly the benefit of IVUS, is the question? So, because IVUS has a deeper penetration into the vessel. So can you comment on that?
Well, the problem is with the IVUS that the ultrasound is attenuated after the first layer of calcium, so you cannot estimate the thickness of calcium with the IVUS, only with the OCT, because we have not this completely shadow of the ultrasound in the IVUS, in the OCT, as we have that in the IVUS. So to judge on the thickness of calcium, you need OCT, and it cannot be done by the IVUS.
Okay. So coming back to the case,
yes.
We see here now the preparation of the balloon. You have to de-air the balloon. That's very important because the air interferes with the sonic shock waves. One question is the deliverability of the balloon, and you will see that we had a little bit of trouble to get it in, but not very much. I mean, just standard catheter, standard wire, a little bit of resistance, and here you can nicely appreciate how the balloon is inflated with 4 atmospheres, a little bit under expanded, and then we start the shock waves. It's always 10 shock waves given for one period. Then you open the balloon up to 6 atmospheres, deflate, let the patient recover in the vessel. But this takes only 10 seconds, the one shock, periods of shock. And you have 8 times the possibility to deliver 10 times of shock.
So you can deliver 80 shocks.
80 shocks. You can see that on the display in the middle part of the video. Because this was also one question. Do you need mechanical support, for example, for this procedure? No, you don't need that, except when you're working on the left main and this is the last vessel maybe. But it's only maximum of 10 seconds when delivering the shock. And then you can deflate the balloon, leave the balloon into the lesion, wait if the patient recovers, ECG changes, recover, whatever, and then inflate again to 4 atmospheres. And here you can see the results, angiographic result after the delivery of, I don't remember exactly, 70 shocks, I think.
70, yes.
We did yesterday. And then we did the OCT run again, which is seen here in the video. And you can nicely see that we had really a lot of cracks into the calcium. I think there you can see some of the cracks, which is shown here by Holger during the analysis. So very effective in terms of lesion preparation, what we can see here in IVUS, and I think you can nicely appreciate what you just mentioned, that there's heavy calcification, and you can nicely appreciate the depth of the calcium in the IVUS analysis.
Nikos, just tell us something about the length and the sizes of the balloon.
Yes.
I think it's very important to know that, because that is one of the factors which is which do you have to realize because of the length of the lesion. So you have, if I understood you correctly, so you have to deliver 10 pulses per lesion in twice. So you have 20 impulses at one region, and then you have to replace your balloon.
Well, it actually depends, of course, on the lesion length. So if you have a very short lesion, very heavily calcified, you can also leave the balloon in one place. If it's a short lesion, you apply your pulses, and if you have a complete expansion of the balloon, you are done. If you have a very long lesion, because the balloon comes in 12 millimeters length only, you have to you start distally, apply 2 times of 10 pulses, remove the balloon a little bit, pull it back to a more proximal lesion part of the lesion. Again, you can inflate, get your pulses, or give your pulses, and then put it back a little bit more proximally. So you can work for roughly 40 millimeters. This is the length you can treat with one balloon. And the balloons come in different sizes, starts from 2.5 and goes up in 0.5 millimeter steps up until 4 millimeters. And again, only 12 millimeter length, so it's very standardized. And that's something maybe people should know, that you can treat short lesions, long lesions, but you have only 80 shocks available for each lesion.
Nikos, tell us something about your choice of a 3.0 millimeter balloon. Which size you should use if you have measured the reference lumen of about 3 millimeters? So
the good thing with intravascular imaging is that you have an exact estimation of the diameter of the vessel, of the reference vessel. So that was the reason why we chose a 3 millimeter balloon, because you want to end up with a 1-to-1 1-to-1 sizing of balloon to vessel diameter. Why is that? You want to have a complete adaptation of the balloon to the vessel wall, which allows you a more effective delivery of the shock waves. So that is always the goal. Go 1-to-1 vessel to balloon size so that you get perfect adaptation of the balloon to the vessel.
Nikos, we have seen now the OCT images in our case, and as you mentioned, we have this microfractures there. The question is now, is it enough? Do we need another step before we place our stents, or are we satisfied with these results coming from the angio and the OCT?
So, yeah, I think there are a couple of points you have to have a closer look at. First of all is how is the shockwave balloon expanded with 6 or 8 atmospheres. I think this is the first thing after you have delivered your shocks. If you have a complete expansion of the balloon, I think you can be pretty sure in different projection, of course, that you have a complete opening up of the
this
lesion.
is, I think, a good point that you use different projection, just to point that out.
Yeah, I think that's important. I personally always choose the projection where the lesion appears the tightest, but it doesn't make sense to change the projection during delivery so that you can see if there may be other areas of the vessel where you don't have a complete expansion. I think that's very important. So there are two scenarios. Your balloon is completely expanded. You can then do, like we did it here, another IVUS run to see how, OCT run to see how it's expanded. This is one possibility. The other possibility is that you don't have a complete expansion.
I don't want to interrupt to just look at this nice results before the pictures has gone. Beautiful result after stenting.
That's the result after stent implantation. So you can nicely appreciate a complete expansion of the stent. We checked that in OCT again. That was a little bit too fast for us. We're talking too much and the video is too fast for us, I think. But coming back to the point, one scenario, your balloon is completely expanded. I think it's fair to say that you can go for stent implantation at that point. If you see that the shockwave balloon is not completely expanded, I think in that case, I would personally do another run of imaging. And if you have the impression that there are really underexpanded parts of the vessel, I would go with a non-compliant balloon. Next step would be an OPN, ultra high pressure balloon, that you really expand the lesion. And if that's the case, you can proceed and go on with stent implantation. In this case, you may have seen that in the video, we had nice expansion of the shockwave balloons already after 2 or 3 runs. Yeah. So 20 or 30 pulses. We saw very nice opening of the balloon, and then we went on with implantation of the stent. There's one question, Holger, maybe you can answer that. How often do you need more than 80 shocks to treat a lesion?
Oh, that's really rare that you need more than 80 pulses. Of course, if you have a thickness of more than 5 millimeters, it could be very hard to crack this calcified structure. However, also in eccentric lesion, but I think we talk about this in the second case a little bit more. However, I think in the most 99% of cases, 80 pulses are enough. However, if you have a long lesion, sometimes this could also then an indication for another device like Rot Ablation. You can also use Rot Ablation in these situations where you have a long lesion situation. However, I think 80 pulses are in the most cases enough to treat effectively.
This is a nice keyword, Rot Ablation. One question is IVL a replacement for Rot Ablation? Can you comment on that?
Well, we can look at the slide maybe which we have prepared just to look at the possible algorithm. A lot of physicians have discussed that point. If Rot Ablation will be replaced by the IVL, or do we have rather an additional a weapon in our armamentarium to treat the calcified and complex lesion. And if you look at this nice algorithm coming from Di Maria, which was published in the Czech last year, you can see that I think the first question we have to talk about is the balloon crossability. If there is no balloon crossing, of course, then you can not use the IVL. You have to go for the atherectomy, which is in that case the optimal device, just to have a lesion preparation followed by an optimal balloon expansion. If this is not the case, so you have always the possibility to add a second device with the IVL and can treat the lesion properly before you come up with a stent. So if you have the other situation that the balloon can cross the lesion, so you will predilate, of course, and then, as we have discussed in the first case, the very important information coming from the intravascular imaging, that you have this 180-degree calcium arc, the length and the thickness of calcium, you can decide and use the IVL as a first-line therapy in these cases. And if you have the optimal expansion of your lithotripsy balloon, you can put a stent in. If not, you have to decide to go to bail out with other devices, as you mentioned before. I think this kind of algorithm brings us to the point that we have not competitors around the complex lesion regarding the Rot Ablation or the IVL, but rather we have some additional tools now available which can be applied to the complex and calcified lesions.
Yeah. Thank you very much, Holger. Maybe one question at the final end. It says stent implantation. And one question is, any preference for any stent in calcified lesions? If you can choose whatever stent you want, any preference?
As you know, and as we all know, the radial strength of the modern and second or third generation drug-eluting stent is always the same. So I think we have thought that maybe thin stent struts are not that good, as we have learned that from the second generation devices. But even with the 60 micron strut thickness, we have this radial strength, and the recall of the stents is almost similar to the oldest and older stents. So I have no direct preference. I would choose whatever you have in your cath lab.
Yeah, I think that's a very clear statement. And maybe we should proceed.
Well, let's go to the second case.
Yes, there was already the question, how does IVL behave in Ostia lesions? And by chance, we have the case for that. This is the second case. It's a 79-year-old male. Also, risk factors, hypercholesterolemia and hypertension. It's interestingly, very identical patient. This patient has a severe aortic stenosis and came to our clinic with cardiac decompensation 2 weeks ago. Typical angina, a lot of edema. And when we did the workup, we detected a severe aortic stenosis and also coronary artery disease, which was diagnosed in the past already, but was more severe now when we did the angio. The next slide, you can see that we did, of course, an angio in order to evaluate the patient, also for severe aortic stenosis. And we detected a severe ostial lesion of the right coronary artery. And we also planned IVL lesion preparation. We did IVUS because it was an ostial lesion. The clinical indication for our procedure was that the patient had angina, dyspnea, and you will see in a couple of minutes that we had to deal with an eccentric calcified coronary lesion, very ostial disease. And I think we can start with the video now. So yeah, here you can appreciate the very ostial lesions. It's again RDC3 catheter, heavily calcified in the ostium. Again, standard wire, samurai wire. You can see that it was not too difficult to wire the lesion. Wire is now in the distal RCA. And we went for IVUS in this case because of the better imaging. You can see now the IVUS advancing into the right coronary, and here you can see really heavy circular calcification. I think it's a very nice example. You can see this, you can appreciate a little bit of the thickness of the calcium, but not like in the IVUS case before. We of course did some measurements for the reference diameter. I think we came up with 4 millimeters of reference diameter, and very tight combined eccentric and circular stenosis. A little bit difficult to appreciate in the angio that we have combination of eccentric and concentric lesion. It looked a little bit more eccentric than concentric, but you see in the very ostium it was very concentric, more or less 360 degrees of calcium. And these are the surprises, right? You sometimes experience when you do these interventions, especially on the ostial RCA, that you're surprised that you can't dilate the true ostium of the RCA, and this is the reason for that. You can see that in the IVUS, heavily calcification. If you go a little bit longer there, you can see that it's more or less 360 degrees.
Just to wrap up a little bit, the last question you asked me, you cannot see the thickness of calcium there. There is the shadowing of the ultrasound, as you can and may appreciate here in this nice slide. So
only shadowing, as you can see here. So really heavy calcification, right?
Yeah.
And very circular. You can appreciate no other structure beyond the calcium.
Well, it's, I think, a very interesting case looking at this heavily calcified lesion. So I have just a question regarding your setup, because you just mentioned, by the way, that you used a standard wire. Maybe the question is if we plan to go for IVL, because this seems to be a crossable lesion with a balloon. Do we need some other devices? Do we need an extra support wire, or do we have some other things in mind?
Yeah, I think the important point is, of course, to be prepared for difficulties. I think this is definitely very important in these cases. In all cases with heavy calcification, I think you need an extra support wire in your cath lab. I think you need some kind of mother and child catheter to strengthen your support if you need. You need, of course, some extra backup catheters, maybe also in not only 6 French, this is all 6 French what you see today, but also in 7 French if you experience any difficulties. Of course, as a bailout strategy, you need also, I think, rot ablator in your cath lab. If you are unsuccessful with your primary strategy, maybe you don't get your balloon into the lesion, what we discussed in the algorithm. So I think you need to be prepared for both arms, that you cannot proceed with the balloon into the lesion, and the case that you can proceed with the balloon into the lesion, and then you can start. But in these cases, you sometimes need extra backup. And I think you definitely need the armentarium in your cath lab for these patients and lesions where extra backup is important.
Coming back to the case again and looking at the IVUS pictures, we have seen that we have this concentric calcification, but we have some regions, several regions where we have this eccentric calcification. So the question is now, is the IVL system as effective as it is in concentric lesion? So what do you think about that?
I think this is still an ongoing debate. What we see from the clinical experience is that we have nice results also in eccentric lesions.
Well, we have the slide in.
Yeah, we have a slide for that. Maybe we can can go for that. What we see in this eccentric lesion, this is small data, as you can see, but on each of the pictures, you can see on the left a eccentric lesion and on the right a concentric lesion. The first and important thing is if you treat an eccentric lesion, you inflate the balloon. You can see that the emitters are more distant to the eccentric plaque because the balloon also changes to the non-calcified side of the vessel. If you compare the first picture, left and right part of the picture, you can see that in the concentric lesions you have the emitters closer to the calcium, and this is different in the eccentric lesions. If you then apply the sonic pressure waves, this is shown in the middle of the slide, you see that for the concentric lesion, you have a very uniformly delivery of the sonic pressures. They go to the calcium, they hit the calcium and induce the cracks into the calcium. On the middle picture, on the left side, you can appreciate that in the eccentric plaques, you have, of course, the sonic pressures going into the plaque, but because it's an eccentric plaque, it only goes effective on one side, in this case from 4 o'clock to about 9 o'clock. You can crack the calcium in both cases. In our experience, it's that you need a little bit more pulses in the eccentric lesions than in the concentric lesions to open up. I think in these cases, it's especially important that you look at different projections, see how your balloon develops, and if you need even more pulses than you maybe expected in the beginning. So I think for the eccentric plaques, it's very important to have a very close look at the expansion of the shockwave balloon. I think this is major, and maybe deliver a little bit more than for the concentric plaques. I think that's a good tip for the eccentric plaques.
Thank you, Nikos. The reason why you have to use more pulses is because you have not this ping pong effect of the sonic wave, yes, acoustic waves. Okay, I got it. So, well, if you look, and just to confirm to that, what you just have said is, if you have the next slide in there, we have this investigated coming from the CAT1 trial, where we have seen that there is indeed the treatment of IVL in the eccentric and the concentric lesion is the same and similar, with a similar effect, looking at the acute gain, for example, or the residual diameter stenosis after treatment. I think so. The eccentric lesion is so you can also tackle the eccentric lesion with the IVL system, and it's not only released to the Rot Ablation system. Both forms and morphologies are treated effectively by the IVL, which is shown in this slide. So, well, I think we can go back to the case, and we can see how you proceed with this really complex lesion.
Yeah, so we're preparing the balloon now. It's connected to the machine. You can see that in the middle picture. And the shockwave is now set up. And now we come with the balloon into the lesion. And this is always the question, and also a question from the audience. How easy is it to cross the lesion with the shockwave balloon? And as you can see here, it's a very tight lesion. And look how nicely the balloon travels along the calcified lesions. We were both a little bit surprised that it went so easy. So sometimes it's more difficult. Any ideas? Oh, here you can see the expansion of the balloon.
It slipped a little bit away.
Yeah,
so
it slipped in. Now we had a better position. It's a little bit underexpanded, especially in the ostial part. And we repositioned it again a little bit so that we really get it into the middle of the lesion. Here we had a nice position, checked it with contrast, and you can nicely see how the balloon is underexpanded with 4 atmospheres. And now we applied the shocks, and very easily with 4 atmospheres and a couple of shocks, you can see how the balloon opened up. I think very, very nice demonstration of the effectiveness. And you see that quite often, that even with a couple of shocks, you already have a better expansion. But the nice thing is, if you repeat the shocks and repeat it, you will see, and this is also the case in this scenario, that the balloon even gets bigger and bigger until it reaches its final destination, in this case 4.0 millimeters.
This is a beautiful example how the balloons pops open after only several impulses given by the generator. And the question often comes up, how do you know that you are now succeeded with your IVL device at that moment? So we just discussed it with the first case, but as you has mentioned earlier, we have this nice expansion of the balloon, and we checked it in 2 projection, and this is the other projection, and I think we are very convinced at that state, only from the angiography, our balloon has opened up very effective.
We did another IVUS run. Here you can appreciate the cracks into the calcium from the IVUS run. We'll see a little bit more in a couple of seconds. You can see these formerly concentric and eccentric plaque, how it opened up.
I watched there was the microfractures again, seen now with the IVUS. It's impressive.
And now we're looking for the reference diameter. We decided again for a 4 millimeter balloon and opened it for a stent, a 4 millimeter promo stent, and opened it up afterwards a little bit. And you can nicely see how the stent opened up. Excellent expansion to 4 millimeters. And we did some post dilatation.
Well, the question before we did the post dilation was, and this is the stop point to ask, is this result now enough, or do we have post dilation in any way? So,
well, I don't know how you do it in Gießen, Holger, but if you treat ostial lesion, we always want to be really sure that you have a nice expansion, that the stent is a little bit going into the aorta. I think you nicely saw that during stent implantation, that you have some kind of prolapse of the stent into the aorta, and that you really need to open it up because it's aortic disease in these ostial lesions. And it's very important that you have a perfect adaptation of the stent to the lesion. We did another IVUS run. And
we can see that if you just started the video again.
And decided that we want to go for a post-dilatation. Not that we saw any under-expansion or that we saw any malapposition, but we wanted to open it up very nicely. And you can see that here, 4.5 millimeter balloon. A reference diameter was 4.0, maybe 4.2. And we did some post-dilatation and another IVUS run because we wanted to see how the stent adapts to this heavily calcified lesion. This is something I think very interesting and very educative in these ostial lesions. You will see that in a second. Here you see the stent expansion nicely adapted to the vessel wall. And the closer you come to the ostium, the more calcium you can see. We did some measurements to estimate the eccentricity of the vessel after stent implantation.
Well, yes, as you mentioned, the eccentricity is one of the key points here. As we know from the bioresorbable scaffolds, we have learned that eccentricity goes along with a bad outcome, and that's the reason why we want to avoid this eccentricity after stent implantation. And if you look here, we have this ratio of about 0.7, 0.75. The question is, should we do anything else, or are we satisfied with these kind of eccentricity? What do you think about that?
Yeah, yesterday we were certified with that result. I think taking into account that we really had very heavy calcification, and we had a nice opening of the stent. We had, I think, very favorable index, so that's why we decided to leave it like that. Next step would have been ultra high pressure balloon, maybe to adapt it a little bit more to the or to reduce a little bit more the eccentricity. On the other hand, we know with this thin stud stents in the ostium that we maybe don't get a much better result as we had yesterday, and I think we were both satisfied with that result. Okay. So yes, Holger, coming to this case, back to this case, there are a couple of questions, and maybe you can tell us a little bit from your experience. How often is it not possible for you to cross the lesion with an IVL balloon?
Of course, this can happen. However, I was astonished in the first cases how easy, as you mentioned also before, that how easy you can deliver and approach the lesion. And yeah, there was an improvement from the first to the second gen, and with the second gen balloon, it's really easy to reach almost every lesion. However, if you have some problems, which can occur, of course, then as we had discussed in our algorithm, well, you have to decide maybe to pre-dilate with a 2 millimeter balloon if it's not working. So you can, and you have to go to the Rot Ablation. But concerning your question, in the most cases, you can deliver the IVL very properly.
In terms of crossability, can you compare it to a scoring balloon? What is your experience? Same, easier,
well,
more difficult?
If you look at the rational parameters coming from the cross-section, it should be more or the same. However, if you think about your devices on the shelf, it's sometimes harder to reach the lesion with a cutting balloon. This is not the case with the IVL. However, you have to be prepared. As we discussed, you need a backup which helps you to facilitate, which facilitates the delivery of the balloon. And of course, there are other devices like guideliner or extra support wires, which has to be in mind by using this new device and this new weapon.
I think a rational stepwise approach would be first do a pre-dilatation with a smaller...
If you are not sure, you should always pre-dilate.
Do a pre-dilatation with a smaller balloon. If you have still trouble to get the balloon into the lesion, maybe use some mother and child catheter. It's 6. You can use all 6 French systems because the system is more or less 5 French. So you can use a 6 French mother and child system. All these steps, maybe other wire is also body wire is also something what you can use. You can also leave the body wire during shockwave application, so no interaction with wires. This is very important for bifurcations.
That's a very good point.
And this is also something what the people want to know from us when you treat bifurcation, especially distal left main. Can you do it?
Yes.
What is maybe the advantage compared to other devices? Do you always need support, impeller support? This is a lot of questions addressing this topic. Do you need the impeller support? Any other MCS? What you need for a lesion for a shockwave? Maybe we can discuss that a little bit more in detail.
Well, regarding the question of bifurcation, I think it's a possible advantage, a potential advantage of the IVL, because if you look at the Rot Ablation use, you have to diminish your or to remove your wire while you Rot ablate the one vessel, and that is not the case with the IVL. So you can treat the lesion with the IVL having in place 2 wires, and this could be one of the advantages, of course. If you have to use always a mechanical support, LV support, if you are treating the left main, possibly not, because there are other factors which are responsible for choosing LV support. However, in some cases, think about the last remaining vessel situation with reduced LV function. So this could be makes the procedure much more convenient and easier for you if you have the Impel device maybe in place.
Yeah, definitely. I can remember a case where we did a Shockwave case in the left main, and we really had no contractility during the phases of inflation. And there, of course, it's really good to have some left ventricular unloading device, I would call it, because otherwise the ventricle goes up and inflates like a balloon, where we don't want to have in this situation. Very important. Another question, any indication where you can't use IVL? Can you remember anything where you can't use IVL because of special situation in the coronaries? Anything?
Well, I cannot remember at any case. Of course, there was only the situation where we cannot reach the lesion. However, then we had to go for the Rot Ablation.
So you can use it for distal lesion, medial lesion,
there's no contraindication at all.
Main. So at the moment, no indication, which is where you say there's no way to.
The only limiting fact is that you have only 80 impulses and that you are reduced to 40 millimeter, as you said before. And I think there are no other contraindications so far.
IVL possible after first attempted failure? Anything where when you have a failure of a balloon expansion, can you use it another time? That's one question. Is that what you would use?
Well, if you go for predilation with a non-compliant balloon, for example, of course you can use the IVL in a step-up algorithm. If you have this under-expansion, if you have this dog-boning situation of your balloon, you have to think about other possibilities. Normally we had used the cutting or scoring devices, and in my opinion, now we have a device where we can use in first line just to open up the vessel properly and to have this good expansion of your stand.
Can you use a second Shockwave balloon in the same lesion?
The company will be grateful if you use a second balloon. However, I think as always in your clinical decision making, I think if you need, of course, a long length or long distance, maybe it's better to have the Rot Ablation on board. However, there are some situations where you have to can use the IVL catheter twice, or you have to use another one. Sometimes we had this also, which is maybe also to mention that the balloon ruptured sometimes for any reason, because think of the sharp calcium edges in such lesions, so the balloon can rupture. However, they stabilized the layers of the balloon so that this should not happen anymore. However, it can happen, and for that reason you might have to use another device in these lesions.
Any problems with balloon rupture?
No,
did you have experience any problems?
No, we had because sometimes it's just in the situation where you have to replace the balloon and not during the treatment of the calcium. And however, but this is not a problem at all.
Even if the balloon ruptures, there's really no problem, no dissection, no vessel closure. So it really appears really safe, even if the balloon ruptures, because you do de-air it in a very excellent fashion. Okay, I think, Holger, we are more or less at the end of our session.
Thank you very much for having me here.
We have some take-home messages for you, some summarizing the cases from today and the experience we talked about. So I think the treatment, Holger, we can say that of concentric and eccentric calcified lesion with the intravascular lithotripsy is a safe and effective procedure. I think it's easy to use. So this is something which is really nice for the intervention cardiologist. It's a monorail system. It's 6 French compatible. You don't need a lot of backup. You can sometimes need backup, but it's not for the standard procedure. You can use it in different ways. You can use it as a first line strategy. If you say, well, this is a heavily calcified lesion, I have done my imaging and I see there's very concentric calcification, then I use it as a first line therapy. Or you can use it in failure when you have failure of other lesion preparation devices. Say you use an NC balloon, doesn't open up, you have dog boning, and instead of proceeding to a ultra high pressure balloon working with 50 atmospheres or whatever, you can step down and say, well, I can try to use the Shockwave balloon, applying 4 atmospheres and 80 shocks. Maybe this gives me more success and is a little bit safer. I think we talked a lot about intravascular imaging and the important role of intravascular imaging so that you don't experience any surprises within your calcified lesions, and it can optimize therapy, I think nicely shown in the last case with the IVUS. And of course, we all are working on that, especially Holger also in Gießen, working on further trials so that we have really more data available. We have the CAT3-4 studies ongoing so that we really develop more data on the shockwave therapy in order maybe next time to discuss a little bit more deeper about the doses of shocks, something which is still open. Do we need 80 shocks in every lesion? What's the optimal doses of shocks? Some open points we still need to learn a little bit more. It was my great pleasure to have you here, Holger. Thank you very much for coming to Trier. Thank you very much for asking so many questions. I hope we could address all your questions, all your open questions. You can also have a look, maybe if you joined us later, you have the option to have a video on demand, so you can look at the videos, and a lot of these questions which came up at the end of the discussion were answered in the beginning of our web symposium. So have another look at the website and on the video on demand. Have a nice day, and hope to see you soon.